So hello and good afternoon, everyone. I'm Nida, and today I'll be presenting my protocol, which is still work in progress, um, uh, which I've been developing during my fellowship. It is on predictors of healthy brain aging among Pakistani adults, the mediating role of resilience. And this work is supervised by Dr. Vikram Patel and Dr. Zulmiri from the Khan University. I'll start with the background. Healthy brain aging. So healthy brain aging, it refers to the preservation of cognitive function and brain structural integrity as we age. It is distinct, of course, from pathological processes like Alzheimer's disease or vascular dementia. So the WHO emphasizes the importance of understanding factors that promote healthy cognitive aging and combat dementia. Aging typically involves gray matter volume loss, that is the frontal and the medial temporal regions, the white matter degradation, and reduced network connectivity that correlates with gradual declines in processing speed, episodic memory, and executive functioning. However, not all cognitive abilities that decline, semantic knowledge, it tends to remain stable or even improve into later age. So the goal of healthy brain aging is to experience these normal changes without crossing into clinical impairment. So when we talk about clinical impairment, dementia is one of the clinical impairments which is commonly found globally. We can see that about 57 million people, as reported by WHO, in 2021 had dementia, and it is anticipated that will reach up to 130 million in 2050. About 2 to 10% of dementia cases, they start before the age of 65, with prevalence doubling every 5 years after 65. When you talk about high-income countries, dementia prevalence ranges from approximately 5 to 14% in older population, with significant variation by age and region. And in low and middle-income countries, the dementia prevalence is 60% of global dementia cases. When you talk about South Asia, the dementia prevalence ranges from approximately 3 to 3.5%, with a significant variation across countries and of course, it increases with age. So when I talk about Pakistan, the incidence of dementia in Pakistan is estimated to be between 150,000 to 400,000 individuals. And in Pakistan, currently approximately 8 to 10% of population over 65 years experience chronic memory loss. So stress, it is shown in literature, it has a relation with dementia. When you talk about psychological stress, it occurs when environmental demands exceed individuals' perceived coping resources. Chronic stress can lead to sustained elevations in glucocorticoid levels, which may underlie cognitive impairment. Prolonged glucocorticoid exposure is linked to structural alterations in the hippocampus and prefrontal cortex. Stress is associated with increased smoking and reduced physical activity, both of which are significant dementia risk factors. Stress, it contributes to hypertension as well, which further elevates the risk of cognitive decline and dementia. So cognitive health is influenced by a combination of direct neurobiological damage and indirect lifestyle factors which are driven by stress. So resilience, which is viewed as either a stable trait or dynamic process, it buffers individuals against negative effects of stress. Higher resilience is linked to improved quality of life and low depression rates in older adults. Resilience, it may protect cognitive function through adaptive coping behaviors and by regulating the HPA axis. And it is likely that resilience is a mediator for healthy brain aging. Enhancing the resilience could represent a potential intervention strategy to reduce the adverse cognitive effects of perceived stress. So resilience is not just a personality trait, it is a dynamic process that operates through physical brain changes. It protects the brain by slowing the structural decline, that is atrophy, and modulating the immune responses. Lifestyle and psychological factors are the inputs that drive these mediating effects. So this is a conceptual framework for healthy brain aging, and I would love to hear from you afterwards whether I should add in more primary drivers and predictors, or anything that can improve this conceptual framework. So you can see the primary drivers, that is the predictors, and then the mediators and the outcomes. So the outcomes that we'll be focusing on in this study is the cognitive vitality, and the functional independence, right, which is a very integral part of healthy brain aging. So the primary drivers of the predictors, as per literature, are some biological and health characteristic that influence the metabolical health, and that is, low, diabetes, blood pressure, cholesterol, appropriate BMI. Genetic factors, they do have an important role in, causing if you talk about the cognitive impairment, it does have an effect. Then when you talk about neurological integrity, that is brain volume, cortical thickness, and no neuroinflammation, it has a positive impact on, the health, on brain aging. Then comes the behavior and the lifestyle factors, which is physical vitality, that is vigorous and moderate physical activity. Nutritional patterns and Mediterranean diet, it has a positive impact of healthy brain aging, and sleep hygiene, that is good duration and quality of sleep. Then there are a few psychosocial and environmental factors, that is like religious participation, social engagement, and family support. Early life determination, such as high education attainment and high socioeconomic status, and mental well-being, that is purpose in life, life satisfaction, and no depression. So resilience is shown to act as a mediator between the predictors and the outcome. And the mechanism that it follows is adaptability to stressors. It compensatory strategies, that is, it maintains function and avoids breakdown, and translation of social support and mental stimulation. So when you talk about cognitive vitality, it is preserved memory, executive function, and processing speed. And when you talk about functional independence, it is to perform the activity of daily lives without any assistance. And then flourishing is one important construct that also has a positive impact on healthy brain aging. So there are studies from LMICs on aging. We can see there was a study from South Asia, which was across 8 countries on all-cause dementias. And the 3 predictors that they found were associated with high rate of DLEs and death due to metabolic risk were high fasting blood glucose, tobacco, and air pollution. A study from India, it showed that that tobacco and the APOE4, that is one of the genetic factors, it is a risk factor for cognitive impairment. While education, that is high educational status, and intake of fruit and vegetable, it was protective for cognitive impairment. Then there was this was again a study that was done in various parts of South Asia, in which they found that there was inadequate funding and shortage of professional, which was needed for the geriatric specialist. Then from Latin America, we can see that the social determinants of health, they were predictors for cardiometabolic factors as well as mental health factors. And when we talk about global LMIC, again, depression, diabetes, and low literacy, they were found to be predictors of high risk of conversion from mild cognitive impairment to dementia. And from Africa, we can see that age, education, and household wealth. That the outcome that they were looking at was validation of Oxford Cognitive Screen for LMIC, and they found a significant association between cognitive impairment and age, education, and household wealth. So these are a few studies that have been conducted in Pakistan, and you can see that there was a study done. There was a study in which they found an association of TBI, that is traumatic brain injury, with accelerated aging and increased dementia risk. Then there was poverty was found to be strongly associated with increased risk of dementia. And another study found that hypertension and depression itself, they were found to be significantly associated with the Alzheimer's and dementia. And then there was another study that found that being female and those with formal education are at significantly, without any formal education, were significantly at high risk of having cognitive impairment. And then there was another study that found that education and social network had a positive impact on cognition, while age and neuroticism had a negative impact on neurocognitive function. So the gaps that I've identified and that is leading me to do this study are, firstly, there's lack of psychosocial data. So we can see that most studies focus on disease or poverty, and limited data exists on positive psychological drivers. So through this study, we want to focus on resilience and flourishing as a protective factor against cognitive impairment. When we talk about the methodological uniformity, current studies, they often rely on single method cross-sectional designs, while through this study will be a sequential exploratory mixed method for deeper integrated insights. The tools that are available, they're Western-centric tools. So by conducting a qualitative study, we want to explore the Pakistani cultural concepts of well-being to adapt the tools. And lastly, existing research is reactive, that is, it focuses on late-stage dementia rather than proactive. While through this study, we want to identify modifiable psychological targets for early-stage lifestyle interventions. So the overall aim of the study will be to evaluate the determinants of healthy brain aging in Pakistan with a specific focus on mediating role of psychological resilience in maintaining cognitive vitality among people aged more than equal to 40 years. The specific objective will be divided into 3 phases. So the first phase will be to explore how resilience is understood, developed, and sustained among Pakistani adults aged more than 40 years, and to identify culturally grounded pathways through which individuals adapt, flourish, and maintain well-being in the face of adversity. And this will be a qualitative phase of the study. Then the second phase will be to conduct transcultural adaptation and validation of stress, resilience, and flourishing tools. And then the third phase will be to identify predictors of healthy brain aging among cognitively unimpaired Pakistani adults aged more than 40 years, examining resilience as a mediator between stress and brain aging. And this will be a quantitative phase of the study. So you'll come to the material and methods. As I've told you, it will be a sequential mixed method exploratory study with 3 phases. So phase 1, that will be qualitative. It will be a community-based participatory research using ethnographically informed qualitative methods. Sampling will be purposing, sampling will be performed, and we will be doing ethnographic interviews, focus group discussions, life history narratives, and in-depth interviews. It will be conducted in a community setting, and we still need to decide the community that we will be targeting. And the sample size will be approximately 40 participants. We'll recruit participants until the data saturation point is reached. So eligibility, men and women over 40 years with proficiency of English and Urdu, that is the national language of Pakistan, and who will provide informed consent. We'll exclude all those individuals who will have Alzheimer's disease, dementia, Parkinson's, or severe traumatic brain injury, or they are on recent substance abuse, or with uncontrolled major depressive disorder or use of Alzheimer's disease medications. So a community advisory board will be formed, which will be recruiting, people from the community, the leaders and different, stakeholders. And they'll have a central role in advising on the methodology, community norms, and cultural language. And they'll assist in recruitment, tool adaptation, and integration of findings. Then we'll conduct some focus group discussions and in-depth interviews of the targeted sample of 40 participants, until data saturation is reached. And of course, all the modification will be submitted to ERC based on the community advisory suggestions. So the plan of analysis, we will do a thematic analysis conducted by NVivo software. Grounded theory will be used using a dual deductive and inductive framework, and there will be constant comparative methods that we utilize to define the emerging categories. So then the phase 2 will come, in which we'll do the transcultural adaptation, which will be, the qualitative findings will guide the transcultural adaptation of the tools, and we'll focus on these 3 tools, that is the stress, resilience, and the flourishing tools. And we'll explore the culturally relevant constructs and assess the adequacy of the existing tools. Then we'll do the translation validation of the tool, because the tools are not translated and validated in Urdu. The tools for resilience will be the CD risk 10, and for flourishing will be flourishing scale, and for stress it will be LEC 5. The GRAC translation into English and all the procedure, that is the standard procedure calculation, will be followed. We will be conducting content validation of the tools by sending it to 5 experts who will assess the relevance and clarity of the items of the tools on a Likert scale of 1:4. Content validation index will be calculated with more than 0.7 considered to be acceptable. We will also be doing construct validation by validating the established these tools against the established Urdu tools, such as patient health questionnaire and the generalized anxiety disorder scale. Then we'll come to the phase 3, that will be the quantitative part of the study, which will be a cross-sectional study. And we will be assessing the participants at the time of recruiting through these validated tools. It will be purposive sampling, and the tentative sample size right now is 200, but we'll calculate it and then, maybe it changes. Again, it will be done in a community setting. The eligibility will be very similar. Again, more than 40 years of age individuals with fluent English Urdu and good general health and willing to participate. And we'll be excluding all those with other problems like brain problems such as brain injury, dementia, Alzheimer's, psychiatric disorders, or substance abuse, history of substance abuse. So these are the measures that we'll be collecting our data on. It will be the social determinants of health, that is age, gender, socioeconomic status, educational level, social network and support, then the health and lifestyle factors, which will include medical history, medication use, tobacco, substance use, alcohol use, diet, physical activity, and social engagement and sleep patterns. So these are the tools that I previously mentioned. For resilience, it will be CD risk, which is a 25 items tool. Rating is on like a scale of 0 to 4, and higher score means greater resilience. Then there will be a flourishing measure that is a 12 item secure flourishing. It has various domains which include health, purpose, relationships, etc. It'll again be scored on 0 to 10 and reflecting overall well-being. It is a quantitative tool. And then for stress, we'll be using the life event measure, that is EDC5, 17-item tool, which assesses the traumatic exposure, and it is based on DSM-5. So we'll be assessing the cognition as well, and this is what I anticipate. As per my search, I found this a very good tool. Montreal Cognitive Assessment, which is a rapid screening tool for mild cognitive impairment, and it details the tasks of visual, spatial, executive, naming, attention, and language. It covers extraction, delayed recall, and orientation, and it outlines the standard clinical cutoffs, that is 26 to 30 is normal, 18 to 25 is mild cognitive impairment, and less than 17 is dementia. Then there will be other mental health outcomes that will also be assessed. There will be depression through the PHQ-9, anxiety through the GAD-7, and quality of life through the World Health Organization Quality of Life Scale, and the Quality of Life Enjoyment and Satisfaction Questionnaire short form. We'll also be assessing the intrinsic capacity assessment through the WHO Intrinsic Capacity Index and through the WHO DAL, which will assess the functional independence. And for comorbidities, I found this tool which looked very good. It was a cumulative illness rating scale, which actually it sort of calculates the total burden of chronic disease by rating the severity of impairment across 14 organ systems. And it's on a Likert scale of 0 to 4, and to measure the physiological intensity of each condition, providing a comprehensive severity index of a patient's multimorbidity. And lastly, a tool for sleep quality assessment will be we'll be using the Pittsburgh Sleep Quality Index that assesses the sleep quality, latency, duration, sleep efficiency, and disturbances in medication use and daytime dysfunction. It has a strong reliability and validity, and it is validated in Urdu. So ethical consideration will be taken into account. Approval will be taken from the Ethics Review Committee, the Afghan University. Informed consent will be obtained. Participants will be, of course, informed about the purpose of the study and the risk and the benefits. It will be voluntary participation. Confidentiality will be ensured. Psychological support referrals will be given if needed, and travel reimbursement and refreshments will be provided to the participants. So the plan of analysis data will be analyzed by the Stata version 12. Results for the will be reported as for quantitative as means and standard deviation, and for qualitative as frequency percentages. We will be reporting content validation index for content validation, and for convergent validity, it will be examined through Pearson and Spearman correlation analysis. The reliability will be reported by Cronbach alpha. So we'll be also doing a mediation analysis, in which we'll be using structural equation modeling using maximum likelihood estimation. And we'll be doing bootstrapping with 5,000 resamples. And 95% bias corrected confidence interval will be reported. And we'll be also checking the model fit criteria of the model. So if you talk about the implications of this study, if you talk about the scientific implication, it will reveal a mechanism linking resilience and healthy brain aging. It will advance the role of well-being, that is flourishing in neuroprotection, and it will highlight a bidirectional link between mental health and cognition. When we talk about the clinical implications of this study, it will identify resilience as a modifiable target for prevention, enable early identification of at-risk individuals, and promote holistic brain health assessment. Lastly, for public health and policy implication, it fills in the critical gap in Pakistan and South Asia. It will provide culturally validated tools for local use, and it will inform preventive strategies targeting modifiable risk factors. Thank you.
Thank you, Nida. We have about 20 minutes for questions.
One thought I had was looking at your exclusion criteria and also what you were studying. It seems like it could be worth considering excluding those with sleep disorders potentially from your sample. Also just given the aspect of you also analyzing sleep quality.
That's a good suggestion. Yeah.
I'm wondering what you think the limitations of not having a longitudinal design are over many years, because it seems like, at least from hearing your presentation, that a lot of what can predict healthy brain aging would start maybe years before any symptoms start. And so how do you think about the design of the study and answering the research question about the mediating role of resilience and imagining that a lot of this is happening over the course of multiple decades?
Yeah, thank you, Laura. So yeah, we do plan to follow these patients, but because, the reason I'm presenting it as a cross-sectional study, because for my postdoc, it'll be a 1-year thing, but after that, we do plan to follow these patients, and that is actually how it should be. And we'll assess, how with time, what's happening with their cognition. Yeah, so we do plan to do a cohort study once the baseline information, we are able to collect the baseline information. Thank you.
Thank you so much for this great presentation. I had a thought just piggybacking on what Emma was sharing about the exclusion and inclusion criteria. Are you also considering family history of dementia or Alzheimer's and Parkinson's, and considering that should, what would you consider an individual with that family history to fall under? Would you have them as a part of your study or not?
I think maybe, at the time of analysis, we can adjust that as a potential confounder. But yeah, I think I can discuss it with my supervisor whether it should be in the exclusion criteria or we should include it and maybe sort of, adjust it during the modeling phase. Thank you.
I also have a question that you may have mentioned, but wasn't very clear to me. You mentioned that some of the tools that you will be adapting, these are all existing tools, and you will adapt them through the qualitative phase. Will look could you put that slide, the one with the 2 colors? Qualitative. Yeah, so one of the thoughts I had was, where are you thinking of placing adverse childhood experiences, since they have been shown to have a huge impact in glucocorticoid function, receptors, and the regulation and dysregulation of the HPA axis, and have also been linked with cognitive impact. Will they be in the qualitative aspect, or have you thought about using also this measure that exists of adverse childhood experiences?
So, these measures, as I mentioned, they are validated tools, and what we want to do through our qualitative study, we want to see what are the different constructs that are coming up, from the qualitative study. So we might be sort of, trying to incorporate those for our culture, according to our cultural context, into the existing tool, of course, after taking permission from the developers. But maybe, as you mentioned regarding the childhood, traumatic events, that might be, sort of fit in the stress tool that is actually based on the traumatic events of life. So maybe, that may be the most applicable in this case.
Yeah, because I do think that will have a huge impact on resiliency. The biological systems of resiliency.
Yeah.
As well as the psychosocial.
half the items of non-base are underneath the LEC 5. If you do completely fill it out with timing, you can get physical abuse, sexual abuse, possible domestic violence, stuff like that. It's just incomplete in terms of things like one person, stuff like that. It's incomplete, but.
So I want to just weigh in, I just on some of the comments, and they're really great comments, and the family history of dementia is a really important point because a significant amount of the risk of dementia is linked to inheritable. We don't know what that inheritable risk is, but the ApoE, for example, is part of that whole space. I don't think you need to exclude people. In fact, quite the contrary, I would just include that as an additional risk factor. The problem with the family history of dementia in South Asia is most people don't have ever had a diagnosis of dementia. So in fact, it's an incredibly inaccurate risk factor. You often don't, most people, and also, you're talking of a generation which died in the 60s, before they even turned 60 because of life expectancy being what it was. So it's not going to give you much information, but I think it's an important variable to have. I also agree with the ACEs comment. A good measure of ACEs should be definitely part of your assessment. To Laura's point, the way I would frame the phase 3 is as a pilot. I think what you should frame it as a pilot that is going to, the sample size is really, really small. And to pick up any mediation signals, you're not gonna, it's going to be statistically very underpowered. So you're absolutely correct to say this is your postdoc work. And if you think of the postdoc as an opportunity to generate preliminary data that can then be used to mount a much more definitive, large-scale, externally funded study, I would frame phase 3 then as a pilot of the methods that you're going to use. You'll collect data on, consent rates. You'll collect data on how long the battery is taking, etc. So your framing will change from actually doing all your analyses that you described become more exploratory. But really a more important set of metrics will be the feasibility and acceptability of the research design for those 200 individuals, rather than focusing on the specific results, because you can't really answer those specific questions in that kind of limited. And Laura's also right about the longitudinal design. As you know well, it's really a cross-sectional. It's a fairly limited in terms of even with sophisticated path structural equation modeling and all that, there's nothing as good as actually following people up, and most longitudinal studies will answer many more questions. A couple of other more specific comments I wanted to make is around the validation of measures. Maybe a little bit more thought can go into how you validate. It's very hard sometimes to truly validate because you don't have any independent gold standards for many of these measures. So I'd say a lot of it is about, face validation, with local communities, local experts. You also want to maybe ask yourself about that construct and convergent validation. These are quite complex psychometrics, and maybe as you think of how those are interpreted, whether in fact what you're going to do is really going to be considered enough. I'd say face validation is probably the most important thing you can achieve. And of course, follow a very systematic back and forward translation and all that. One of the main findings of all the papers you reported and of the literature is education is a very important predictor. And this tells you something that along Mercedes's point, that these are increasingly seen as neurodevelopmental conditions. Your cognitive capacity in the first few years, which is influenced both by ACEs as well as by education, actually is a huge unmodifiable risk factor, because when you look at someone 40, there's nothing you can do with those risks. So I would recommend that you consider, when you're sampling for phase 1 and phase 2, making sure you have people who represent the kind of range of educational attainment. The 40 to 50-year-olds in Pakistan, if they're similar to India, a significant proportion will not have received completed high school. So you want to make sure that your sample includes a very significant proportion of people with a representative of the educational level that would have been there when they were children. So I think otherwise you might get very highly educated people, and you may not in fact pick up the full range of risk factors, because education almost acts as a fixed variable here, which will moderate many of the other, analyses. And lastly, I just wanted to suggest to you, and this is, I had suggested you speak to Rita Hamad at the population.
She didn't write back.
No, okay. Well, maybe you can just go to their website.
Okay.
So this is a resource at Harvard which has been running these large, really probably the largest longitudinal studies of aging that's been conducted anywhere in the world. And they include many cohorts in Central and South America. They have in the United States. They also have in India, the Lassi DAT study. My suggestion really, Nida, is to make your data compatible with all these other studies, which are very large and have been extensively published and profiled. Instead of trying to choose measures that you would have to go through a very painstaking process, but also will then be very hard to, as it were, align with these gold standard study measures, I feel that maybe you should look at those studies and examine whether the measures you're using are the ones that they're using, and if not, should you be considering those measures? So Lassi DAT, for example, which is, India and Pakistan share almost identical, characteristics in terms of social context and so on. The Lassi DAT is a huge longitudinal study in India, and they have very extensive measures of every single construct that you have described. I'd say that before you try and validate a brand new measure, look at the ones that are already used. South Asia is one big region. If something's already been used in a neighboring country which shares very similar history and culture, then you can spare yourself this whole question of validation, genuine, the whole sort of construct and so on. You still have to do the language and so on, but it can also mean that your data are immediately comparable, your results with other large longitudinal studies that have used the same instruments. So look at their website, and I can introduce you to David Bloom, who's at the School of Public Health, and he leads the Lassi DAT study. So you can also meet him, and he can be a really good person to guide you in your design.
So in this case, then do I need to do a phase 1? Because if these tools are being used in South Asia, and one purpose of qualitative study is
I think the phase 1, what it should inform you is on your overall theory of change. That very nice AI. There was an AI generated. I could make out those are really great ones because they actually they're really great. I mean, it's to construct one of those slides would take me about a week. And I mean, I've used this as well. I've used these, and they really come out to be absolutely. This is a fabulous, framework. So I would use this as the basis for discussion with communities about measures, about variables, about constructs, about how relevant are they for the people that you're going to be conducting the quantitative study. What are the things that are missing, etc. I would say that's a very important phase, the co-production phase at the beginning, because then the quantitative study, once it's designed, you can't. It's very hard to suddenly go back and say, I want to change this. So planning for the quantitative in terms of the design of the measures and so on, I think phase 1 is very important. Phase 2 is a validation of measures. I think the translation, to the extent they're not available, will it be Urdu or Punjabi? Urdu. So, if those measures are already available in Urdu, then you definitely don't need to repeat it. Maybe you just have to read it and make sure the Urdu is the same. But I mean, you wouldn't go through the whole thing again. But not every measure will be available. So at least those that are available, you can just park. And those that are not, your phase 2 will focus on them.
And do you think the measures, that are we assessing the patients, the individuals on, are they, I hope they're not too much, or should we do a sort of a pre-testing to see whether, the participants are actually ready to give so much information, because there are a lot of tools that I'll be assessing them on.
Yeah, well, I think this is the kind of question phase 3 would ask, is how long does a battery take? What is the fatigue? Do you have to break up the interview in order to complete it all? And these are the sorts of, as it were, acceptability and feasibility questions. And so that's why I'm saying phase 3 becomes more of a pilot of the methods rather than answering very specific questions. Those can be exploratory. for reasons of
Yeah.
sample size, the fact that it's not longitudinal. And then you use these data for your much more definitive application for a bigger externally funded project.
Any questions?
I would only add, just because I am also oh, sorry, someone else was gonna. Sorry, I didn't see me. To also add, besides educational attainment, I would try to add people from urban, peri-urban, and rural areas in Pakistan too, because they also have different life experiences. And the MOCA also adjusts to school attainment. So if you're having variations in school attainment, just check out that adjustment.
Thank you.
Hi, I for the phase 1, I recommend you to look at the word ethnographic methodology or something like that.
Yeah.
Because ethnography really requires someone to be there, take notes, and be immersed.
Yeah.
So just for you to look at the language, because I think focus groups and the other method that you have suffice to the qualitative portion of the formative research.
Yeah, I agree with Carolina. You know, that was also a good point that she's raised, is the word ethnography has a very specific methodological meaning. And as Carolina is reminding us, it's a deep immersion, oftentimes over very long periods, where you become almost part of the community that you are interviewing people, you're keeping field notes. It's a very different design. What you're doing is a qualitative study using rapid methods like focus group discussions, completely legit. But I don't think that's, I would call that ethnography. I just call it qualitative. A qualitative co-production, yeah. I just wouldn't call it ethnography. That's a very different meaning.
Okay. Thank you. Yeah.
I was wondering too if the Montreal cognitive assessment has been normed with the population that you'll be testing it with, and if you're including measures of like to test malingering, for example, when you're doing such a long assessment battery to make sure that someone's like giving their all and trying to get it right.
So I think a Montreal scale, it is being used, you know, in a lot of studies in Pakistan. So what do you suggest? Is it okay? I mean, or can I, you know, use some better tool than this?
Yeah, I would just review and make sure that it's been normed. Those guidelines, like the normal range, has been normed with Pakistan.
Okay. I'll just check. Yeah. Thank you.
I mean, that again goes back to the point that I said, if LASI data has used a measure, you know, which has been fully validated in India, you may want to ask yourself, is this worthy? Should I just consider using that? It's already, you know, been tested with thousands of people.
Absolutely.
Any last questions?
Sure. So I genuinely have a question. I'm really interested in the context. So we know that what a person believes or perceives about their illness really determines a large part of how they react to what they do about it. And I think you and I both come from societies which are deeply spiritual. And so I'm curious to hear whether in Pakistan, do they consider more of a medical thing? Do they consider a spiritual thing? How do they conceptualize dementia there?
So, I mean, of course, it depends a lot on the educational status, but spiritual, it plays a very important role. So first, you know, their idea will be to let's just follow the spiritual things and, you know, it'll become better. But then, you know, if it just crosses those lines and then, you know, then they would rather go for, you know, medical treatment. But it depends a lot on education. If, you know, if people have low educational status, they might never go to a medical person for getting themselves treated for dementia. It will be, you know, just following the spiritual thing. So, yes, I think education plays a very important role here.
Just a quick follow-up. So as you were saying, you're planning to follow them longitudinally over culture, which I think is really great, and you'll see a lot of really cool findings there. Are you planning to have a qualitative component with that as well?
Which component?
In phase 3 onwards, sort of in the multi-year follow-up.
Qualitative component?
Qualitative.
I think I haven't thought about it, but I guess, you know, it will be good to have a qualitative component as well. How do you think that will be beneficial?
So I think that with a lot of these qualitative studies, and I'm thinking about other fields, including a big one, which is how social media impacts mental health. A lot of the measures do capture some of the variants, but it's quite distinct from the realities that we're seeing on the ground and how these factors interact, what's happening there. And so at least from my side, we're really keen, really curious to see if a qualitative component can reveal a lot of these patterns
Yeah.
that these questionnaires may not be
Yeah.
throughout the years that you're
I
going.
agree. I think that's a good point.
I wanted to just pick up on one point that Sandy said before we end, and that is the question about spiritual. And you really want to consider that, the engagement with faith-based activities as one of the variables in your that theory of change, the theoretical framework.
Yeah.
It might be there,
Yeah.
but it might be made explicit.
Yeah.
Because I think there is. Obviously, Tyler Vanderweel's work shows that seems to be a very important predictor of human flourishing. And I think that's not necessary. It could be across the age spectrum. So worthwhile, I think, adding that as a variable. The other thing you might want to do with phase one is there's a I don't know how rich the qualitative literature is on this question in Pakistan, but which is how is healthy aging defined? And what does how is unhealthy, so-called unhealthy aging, if you want as a euphemism for dementia, how is it understood and recognized? Actually, that could make a really interesting standalone piece of research. I mean, I did similar work a long time ago in India, and I remember that one of the most important, the paper was published in a very leading journal because one of the most important findings was that most people did not recognize dementia. Because they would just say, oh, he's just growing old, my dad is, and in fact, but in fact, he was not just growing old, he was actually seriously affected by advanced dementia. So that kind of normalizing function, which is a good thing in places where there are no services and there's nothing you can do about it, it helps avoid stigma and so on. But it can also be not such a good thing because it means that if there were certain interventions or advanced life planning, all the stuff which you also want to do. So ask you the question: how is unhealthy aging conceptualized, explained, and acted upon like an illness narrative? But obviously, asking people who are healthy now at this stage of their lives might be a really useful framing for that phase one.
Absolutely. So thank you for the comments, and this is really helpful.